This is going to be kind of a start, kind of like a mini series of acute abdomen using ultrasound, or evaluating the acute abdomen using ultrasound. So I'm going to start off with something fairly bread and butter. Hopefully I'll sprinkle a little bit of seasoning in there to kind of whet your appetite. And then, as you guys know, my passion is basically about ultrasound. So there'll be more to come within this realm, especially megavolvulus, for those who kind of know what my research interests are. Okay, so without further ado, I will get started. For today's talk or session, in addition to the discussions that Jeffrey and Judy and I are going to have, I also have a little bit of audience response, or I want to engage a little bit with Poll Everywhere. So if you have a phone, you can just put your phone up to this QR code and it should take you to the polling page. And then if you're using your phone to watch this, and if you have access to the web, then you can just go to www.polleverywhere or ev.com and then / and then my name. And that should kind of take you to the polling. So hopefully everyone has gotten a chance to kind of grab that QR code. And of course, if you have the app itself, you just put in my name and it should bring you to the polling page. All right, so this is just kind of an icebreaker and kind of gets people started on the audience response system. And I think there's a QR code too that should be projecting to the upper right hand corner. Okay, so far mainly US participants, and then someone else out there. I should probably know my geography a little bit better, or someone just has like really big thumb and or index finger, but that's great. So we have kind of a wide range of people from different institutions. So it would be so wonderful to kind of hear your guys' experience and practice as well, because even though it's bread and butter in pediatric radiology, I'm sure there's lots of ways to cook up a meal. All right. So my main message here for this hour, regardless of everything that I say or show or present, the main message is always going to be, if you want to perform bowel imaging, and in this case, appendicitis, or looking for appendicitis or intussusception, you must use a linear high frequency probe. Obviously, not all probes are created equal, but optimize it to whatever setting that is most optimal, and also obtain cine clips along the course of the colon. So those are the two musts in order to be successful with evaluating for appendicitis or intussusception. All right, so what we're going to do today is kind of go through the protocol of appendicitis and intussusception, has how we do it here at CHLA, then go through some negative and positive and equivocal cases as they relate to appendicitis or intussusception, and then of course touch on some mimickers. So the eyes only see what the mind knows. So hopefully the more mimickers and the more cases you see, the more likely you'll be able to identify things that may not even be appendicitis, or acute appendicitis or intussusception. All right, so we're gonna first start off with acute appendicitis, and we're all clinicians, so I always try to tie in the clinical presentation. Like, does this patient have fever? Right lower quadrant pain? Is there focal tenderness? Can they point to exactly where they're hurting? Anorexia, how long it's been going, any vomiting, etc. So when I do go in and scan, usually we do that with right lower quadrant ultrasound. I do ask those questions, and then I start searching for the appendix. So the appendix can come in a variety of flavors, especially the normal ones. So don't be too caught up or hung up on size criteria alone, or just any one specific sign. So both of these appendices, I believe, were taken to the OR because it's kind of big. There might be some shadowing. Is that stone? There's some free fluid, but they both turned out to be normal. So they were negative, proven in the OR. So these are normal appendix. And the important thing I do want to know is that, aside from them both, I think measuring, I don't have the measurements here, but I think they all measured, 6 millimeters or slightly above that. So despite the, that quote unquote 6 millimeter cutoff that's been previously published, other ancillary signs are definitely necessary to make the full diagnosis of acute appendicitis. All right, so now to kind of go through our protocol. Essentially here at CHLA, we do appendix and intussusception sort of into one, because, you know, on the intussusception, we look for the appendix, and then vice versa on the appendix, we try to look for the intussusception too, if they're at the appropriate age. So in general, what we do is look at all four quadrants. Usually that's with a curve probe, just for improved penetration. And you just want to look to see if there's any free fluid, or any complex fluid collections to kind of suggest like abscess formation or some kind of perforation. And then the other thing we also look for is just kind of screen at the kidneys and the gallbladder. You know, in older kids, like, do they have any cholelithiasis? And then in younger kids, maybe there's hydronephrosis that was not picked up. And I know when I worked at Texas Children's, we actually stopped screening. So we basically just went straight to, you know, if it's appendicitis or an appendix ultrasound, we just look for the appendix. But I think here, because the patient population might be different in that there's a lot of Medicaid type patients. So, you know, essentially this might be the first imaging they have and maybe ever have. So in a way, I have kind of shifted my point of view to, we should screen just in case, you know, we do catch something that could potentially change a lot of management for these patients who otherwise don't have the routine care. All right. So now we want to focus on the bowel itself. So in the setting of, you know, looking for the appendix, you want to do your due diligence in the right lower quadrant, kind of look where the iliac vessels are, because usually that's where the appendix may lie. However, my argument is you can't just look in the right lower quadrant, because, you know, who knows, depending on how the body is built, you don't know where the appendix is. So for me, when I go in to search for the appendix, I actually scan up and down the whole hemiabdomen, because the appendix might be retrocecal and extend a little bit more peripherally. In that case, I have the patient turn away from me and basically use one hand to press the colon out of the way and then scan from the back or the side, because sometimes you can get the identify appendix, even if it's normal, or, you know, appendicitis that way if it's retrocecal. The other thing I do is sometimes the appendix can come off a little lower and then travel medially, you know, that's why they have like that periumbilical pain and stuff like that. So I tend to even go down and then a little bit medial towards their umbilical region, just because sometimes on CT, we all know this, that the appendix can travel fairly far depending on how long it is. And then this here is the terminal ileum. So those are some of the landmarks I usually use and look for in order to find either appendicitis or a normal appendix. So once you do find the appendix, which is, you know, that blind ending tubular structure, then you do want to compress either on still images or on cines, because usually normal appendices will be able to compress. But one thing to note is that people think, oh, wow, compression images, they have to like really compress. But that's not really the case, because on ultrasound, you're already using graded compression. So it's not like you're going to be able to like ultimately smush the appendix to oblivion or like to nothingness. So, you know, just because it decreased only a little bit doesn't mean that it's abnormal. It just probably means you had to press quite a bit to get to view it in the first place. But either way, that's helpful, because sometimes if it doesn't compress or doesn't like squish around or move easily, then that may be a sign of appendicitis or acute appendicitis. The next thing, you know, if you do identify it, then you want to throw on color. I think that goes along with anything in ultrasound. If you see something abnormal, put color on. If it's hyperemic, like in the case up here up top, then yes, that's, you know, contributory to your acute appendicitis cause. But if it's not, it's still appendicitis if it has every other sign. So to me, I feel like, you know, color may or may not be as useful. It's additive, but without it, it wouldn't deter me from calling acute appendicitis. All right, so some questions to my co-moderators. What is the allotted time for, you know, an exam at your institution, and whether or not you screen for the kidneys and the gallbladder?
So as far as the timing, so pretty much all of our exams outside of Doppler exams have a 45-minute slot. You know, it's always a little bit different with ED patients. You know, we try to add them on where we can. We don't necessarily, have to have a 45-minute block in our schedule to fit one of these in. We try to just scan them where we can. It typically doesn't take a full 45-minute slot to scan either of these exams. But, I think just allowing the sonographers, just so they're not continuously scanning all day, every day, building at least a little bit of a cushion into their schedule, I think it's really beneficial to them. But for both of these exams, we have a 45-minute window for each of them.
And do you usually have like a combination, especially in the females with right lower quadrant pain, like something that involves both the appendix and the ovaries, or like, a pelvic ultrasound?
So we build everything into their own individual exam, so we don't have any combined exams. We talked about that. We're kind of revamping our exam coding right now, so we've looked at doing that. But as of right now, everything's separate. So if you want an appendix and a pelvic, those have to be ordered separately. Or if you want an appendix and an intussusception, they have to be ordered separately. And they each get a 45-minute block of time. So
Okay.
Ours is
And then
similar.
do
We
you
have two separate orders, although from the ED, they never order only a pelvis or an appendix. They're always in combination. So we sometimes will take a look at the right kidney. There's some literature about increased echogenicity of the right kidney being another sign of acute appendicitis, but we really don't routinely do that for just an appendix ultrasound, although we do include a look at the kidneys with a pelvic ultrasound. Which is kind of funny. And we also don't always do a screening for the gallbladder unless a separate right upper quadrant is ordered by the, usually it's the emergency department. So we just look for what they ask us to look at.
yeah, that's definitely interesting. When I was in fellowship in Boston, we screened the kidneys there with a lot of things, even scrotals. And it seemed like most exams had the kidneys included, but in Colorado, we don't do that with any of our exams. I'm curious what your experience has been, how often you actually find an abnormality with screening those, if it would be worth adding those or thinking about adding some of those other screening things to other exams.
Yeah, I was kind of like a firm believer because I worked at Texas Children's for like 5 years prior to coming to CHLA. And we just stopped screening just because we didn't find the utility in it. And so once I got here, I was like, oh man, this is kind of ridiculous. But then, it's not too infrequent that we find other abnormalities on our exams. So then I'm starting to kind of change my tune. And I don't, like I mentioned before, I don't know if it's just our patient population, like, we do see a lot of people who really don't get care anywhere else, or probably may or may not even have actual insurance. Just because of the population we serve. And so in a way, we do kind of incidentally pick up things that do require some further workup. So I now would prefer to screen, even though, like I haven't looked at our numbers to actually see if like the actual percentage of what we find. But it's good to know what we kind of do and don't do at different institutions. All right, so moving on, I'm just going to talk about some negative and positive and equivocal cases. And I apologize, I have to like turn off the video for you guys in order to like see my screen on my laptop. So if you're like making facial expressions to like give me clues, I'm going to be completely clueless. So you have to speak up. All right. So this is just for funsies, kind of to engage the audience if you're still out there. This is, once again, a poll everywhere. So if you can kind of put your camera to this QR code up here, or if you came in late, just www.pollev, I think .com/hightween-win. And then, yeah. Let me know your thoughts. Awesome. So yeah, this is kind of a little hard, right? Because there's so many like tubular-ish structures out there. But I think the majority of the people are getting it correct. So this is the appendix, and this is usually how the appendix looks like. And then these are the terminal or distal ileum, and this is an iliac vessel. So, and potentially this could be the appendix as well. But my argument here is that it's hard on a single image or slice to tell that that is or is not the appendix. Even though this is from a cine clip that I just kind of took. So in general, you know, I always advocate, you know, having a cine clip just to kind of confirm for whoever that is reading it, or even for the future person to be like, okay, so this blind ending tubular structure did come off of the appendix. All right, so this is another one. This is kind of like an eye test almost. Where do you think the normal appendix is here? Yes, and essentially, yeah, that dot, now that it's there, is going to cover the entire normal appendix. Exactly. And this is my other argument for a cine clip. So initially, the person scanning it did not recognize that the normal appendix is there. So once again, you know, once we have the cine sweep, maybe you don't recognize it there, but as you kind of go back and go through it, you're like, oh, okay, yeah, that is the appendix. So instead of calling it non-visualized or equivocal, you can actually be definitive and say, hey, it's normal, let's move on. So that's part of the normal one, but on the cine clip, you can actually see the whole thing. All right, so now we're gonna go to something that's like, positive maybe, or maybe a little equivocal. So this is a fairly recent case that we had, and it's a 9-year-old female with abdominal pain. So when you ask the patient, you know, maximal tenderness, the patient points right to the right lower quadrant, and then when you put the probe on it, that's exactly where this this appendix is, and it measures 6 millimeters, and you know, it's non-compressible. So overnight, the preliminary read was fairly, you know, accurate, just kind of describing that it's non-compressible, it's kind of borderline in diameter. However, there's no mesenteric edematous changes, so basically no periappendiceal fat straining or right lower quadrant. So essentially, they're saying there's none of those secondary findings. But the person placed it into the equivocal category and then suggests that, you know, this could be tip appendicitis, consider CT. A CT was done, and it was read as normal, and then I guess the ER monitored them and did not feel like they had appendicitis, and then discharged them. So as far as I know, this is a negative case. All right, so then that brings me to, what are signs that will improve your diagnostic accuracy and not just sensitivity, but specificity? So we all know that periappendiceal echogenic fat has been published before as being one of the most sensitive finding for appendicitis. And so here you can see that there's this tubular structure with mural stratification, and then you can have all of this echogenic fat around it. So I use this a lot. And when I had at my prior institutions, we had GE. So it actually, you know, this is classically how it looks with the linear. However, now I have Canon, so I'm curious to know if anyone else has experience with Canon. I feel like it's a little bit more, you have to tweak the settings a lot more. So here is the exact same patient, exact same time frame, and the exact same probe. However, the biggest difference is that for the bottom one, you know, there's increased depth and decreased frequency. And so it makes the fat surrounding the appendix less echogenic or conspicuous. So I feel like, you know, if you're not looking for it, you might easily miss that. And also, just to note, the focal point is not, you know, where the main abnormality is. So I feel like in some machines, there may be a little bit more tweaking. And so you just have to be conscientious of what machines or what probes you're using, especially at institutions where there are multiple different types of fleets. And so that can be a little bit challenging. And of course, you know, in the chat or whatever, I would love to hear your guys' experience. And then actually with Jeffrey and Judy, like what probes or machines you guys have, and is it sometimes hard to get the fat to stand out?
Yeah, so we have Philips here in Colorado, and I just, you know, relatively recently we changed some of our presets in our machine, and it definitely, we've had some similar experiences to what you're having now with kind of that fat looking more echogenic than I think it really is in reality. You know, getting around that, we found that it's helpful to look at the mesenteric fat elsewhere in the abdomen to see if it's truly periappendiceal or if it kind of looks echogenic everywhere. That's probably been my best problem solving tool to kind of figure out whether I really want to call this a real abnormality or not. But yeah, it's definitely been something we've experienced in trying to, I think, differentiate between artificially increased echogenicity of that fat versus true echogenic fat.
Yeah, I agree. And I love the cines. I feel like on the cines, like you don't just include the periappendiceal mesenteric fat. So even if our tech finds the appendix, they get kind of screening images of bowel elsewhere, and exactly the same way. We compare the mesenteric fat elsewhere to what's happening right around the appendix.
So Judy, do you do cine clips on, you know, like with the screening of like other bowel as well, or just like you're saying like a still image like on the left lower quadrant?
We save cines.
Okay.
So I love cines. My IT guys probably hate me because we take up so much space with all of our huge ultrasound studies, but I find that there's so much problem solving you can do on cines after the fact. And especially on busy days when you just don't have time to get up and scan, the cines save you from having to get up and go back scan a lot, I feel like.
And that was one other thing I was going to mention too is, do you guys take specific images of the terminal ileum or ileocecal valve as part of your standard protocol?
No.
Yeah, we just recently incorporated that. You know, one thing was because we've started doing more TI ultrasounds for inflammatory bowel disease. So we kind of like you've suggested in the past, you know, doing volvulus protocols and pylori studies. We've kind of incorporated that into some other things. So we've started looking at the TI as part of our appendix exams. You know, and I think it's had benefit beyond just giving the text practice looking for it. You know, it gives us a kind of a baseline of what the distal small bowel looks like. And it really, you know, if we can see the TI and see the ileocecal valve, that also helps localize the cecum and then kind of can start our search for the appendix there. So I think that's had some value for us, you know, looking for and it's specifically including the terminal ileum just to increase our confidence in if we see a separate appendix, we can more confidently say that it's actually the appendix and not small bowel.
Yeah, that's a really great idea and thought. Yeah, I never thought about incorporating it into it. We might try starting to look for it. Do you have a lot of success in finding the TI and cecum in babies when you do the mega volvulus ultrasound? I guess we're diverging, but
yeah, it's definitely more challenging. I think we can talk about it more when we talk about intussusception too, but we've also incorporated it into our intussusception protocol. And we've definitely noticed that it's more challenging to find in the age range of kids that have intussusception exams versus appendix exams. You know, in those 1 to 2 to 3 year olds, everything is just smushed together, and it's more difficult for sure to discreetly identify the TI versus a 7 or 8 year old that comes in with concern for appendicitis. So we do have it as part of our volvulus exams too, and we have a challenge, I think, for sure confidently finding the cecum and TI on those younger kids for sure.
With our cines, the techs don't always know they see the ileocecal valve and cecum, but on the cines, you can tell that that's what it is. So whether or not our techs know they're looking at it, they're finding it for us usually.
agree. Yeah, I do feel like you pick up so much more on the cines, especially if you know what you're looking for. So, and hopefully, you know, with all these lectures and talks, like more and more people will kind of have the same eye for those findings. Okay, so just kind of moving on to the periappendiceal echogenic fat, you know, that like, I guess as alluded to before, you know, you don't want fake out, so you don't want to simulate fat, but at the same time, you want to be able to pick up if there is truly fat around the appendix, and then that way it can help you call acute appendicitis in the setting where the size is equivocal. So, you know, both of these cases have diameters or appendiceal diameters of 0.6. And this one, you can even argue might be a little bit compressible as well as this one. So the biggest defining factor here is going to be all of this periappendiceal fat, as well as loss of mural stratification. So you can't really see the bowel walls as well. So like I alluded to before, there's lots of other secondary signs. And there's been a few papers out there kind of looking at it. And I find that both the periappendiceal echogenic fat and loss of mural stratification being really good signs to look for, as well as, you know, fluid distension, like in this case, as opposed to just having like normal stool and echogenic stuff within it. And then along with compressibility, and if you can actually see like a true appendicolith, you know, obstructing and then fluid distally. So all of them kind of add up together. But if you were to just kind of focus on two, I would say like these are my top two or top three. So now moving on to standardized reports. So once again, I've experienced both. So before I trained and worked, we had standardized report. Currently, we do not. What are you guys' thoughts on it? And do you guys use it?
Yeah, I'm definitely a big fan. Yeah, I think it adds a lot of value. You know, like this paper you have here, there's a couple other ones out there. Our report is kind of a mishmash of a couple of these other different published papers. I think it really does add a lot of value. We have a kind of a hospital clinical pathway that the different categories of our reports are incorporated into, as far as, you know, what triggers a surgery consultation. So I think the providers really like it too. Probably about 4 or 5 months ago, we also started including our actual own institutional data in the report. So for each category, we have reviewed, I think, probably about 1,200 exams or so. And we have that internal data for this category has this particular negative predictive value. So, you know, we have a category that says, you know, normal visualized appendix, you know, greater than 99% of these exams are expected to be a true negative. So we actually give them that actual percentage for this particular category has this expected performance. And I think they really like that. I think it really adds a lot of value.
I'm jealous. That sounds great. We, you know, almost everybody includes the same things in their reports, but our group has still not adopted standardized reports. So, you know, we say the same thing different ways, which I think is challenging for them. You know, so my report is the same for each indication, like for different results of the same indication or study type, but other people's are different in our group, which is, we need to eventually get on board to all report in a similar style. Herculean effort.
Yeah, I see both sides for sure, you know, having been at the institution where, you know, this paper was published, and also here where we do not have it. I still kind of use my same standardized reporting from TCH and kind of, but it's funny because, you know, back then, like, it doesn't matter what I say. I just have, like, the ER would just call me, just like Jeffrey alluded to. It's like, what is the appendix score? Like, because they need to take it and incorporate it into it, and then they know the exact percentage. So I am a proponent for standardized report, just for those exact reasons. It's like everyone's speaking the same language. The ER will know exactly what percentage, you know, within your institution, because obviously it varies. You can have your own scores, you can have your own, you know, sensitivity and specificities and all the values per score, but for sure, I think the standardization is helpful. And Judy, we're not there yet either, so that's something to maybe work forward to. So then now we move on to, fine, you know, there's the acute appendicitis, there's the negatives. What about the equivocal ones? And so another study that was also published at Texas Children's, and I'm sure there's probably others, but it's just because, you know, I'm always aware of the ones where I work or where I've worked. And so with the ones that are called equivocal, and usually the ones that are pinpoint in that category is typically, you know, the size is maybe a little bit over 6 millimeters, or maybe there's like a little bit of questionable periappendiceal fat stranding, but nothing else. So that kind of falls into that category, very, very small percentage. But then from that cohort or group, they looked at what actually made it even more likely that they'll have acute appendicitis. And it turns out that loss of mural stratification, and then the periappendiceal fat stranding, and then if you can identify the appendicolith. And then from that paper, you know, of like 100 or so patients, they found that the cutoff was 6.7 millimeters, was a little bit more specific for acute appendicitis. So perhaps, you know, previously 6 millimeters might be a little bit too sensitive. And then, you know, we're just incorporating a lot more negative appendicitis in there. So moving on, you know, what do you guys do when you don't have, or, you know, it's equivocal in your cases? You know, do you just do CT right away? Do you re-image? Or, you know, the same thing if it's non-visualized? How often does that happen? You know, what are some of the next steps that you typically follow? I know that, Jeffrey, you have an algorithm, so it's probably incorporated into that.
Yeah, at our institution, So first of all of the studies you see where the goal of finding the appendix is 80%, I feel like the times were different then. So these days, at least at our institution, the clinical workup of acute appendicitis has changed. We're often getting orders for an appendix ultrasound when a physician hasn't even seen the patient. So they're getting ordered from triage. So the pretest probability is probably a lot more variable than in the studies where, this magic number of 80% visualization at ultrasound is given. And I always say it is a lot harder to find a normal appendix than an abnormal appendix, right? It's like moving around, it's tiny, it's, hiding from you as you're scanning. So we need to relook at our numbers. Actually, one of our techs is working on that right now to come up with some current data. Anecdotally, we're probably closer to 50%. And then once we find the appendix in our categories of visualization, if we see it, we have been successful at convincing our surgeons and emergency department physicians that if it's equivocal, repeat the ultrasound if we see the ultrasound, because if we could see it once, odds are it's going to be seen again if there's still clinical concern, and an abnormal appendix will declare itself. I think that they give a range in the clinical pathway. I meant to review, but I forgot to do that. I think it's between 6 and 10 hours or 6 and 12 hours after the first ultrasound, which they don't always love to do because our ED holding is always packed to the brim. But sometimes they do counsel the patient's parents if they seem like a reasonable family, and then they come back for an ultrasound if the patient still has pain. Yeah, I'll let Jeffrey talk now.
Yeah, so for our internal data, so we have an ongoing QA project that's been going on for several years now, that one of our sonographers keeps track of all of our appendix stats for the sonographers. For each individual sonographer, they keep track of how often they visualize or non-visualize the appendix. And so they kind of keep track of the performance of each tech, and then they kind of send out an aggregate for, our whole group as a whole. It varies. We kind of range between about 70 to 75% visualization. So that includes fully visualized and partially visualized appendices. I think we have a little bit of an advantage here in Colorado just because our rates of childhood obesity are much lower than elsewhere in the country. So, but we are at about 70, 75% visualization. For the non-visualized appendices, so we have an additional kind of internal project trying to assess body habitus and seeing if we can triage those patients further. So we actually do a measurement of the abdominal wall fat. And so what we found so far is that of a non-visualized appendix, if their subcutaneous fat thickness is less than 7.5 millimeters, those are almost always negative. Even if we don't see the appendix, if they don't have any secondary signs, we feel very confident. We actually put those in the same category as a normal visualized appendix. When we say those are, greater than 99% likelihood of being negative. If they're greater than 7.5 millimeters of abdominal wall fat thickness, then those get put into a separate category. It's still a pretty high negative predictive value. It's in the low 90s, but we at least, tell the clinicians that we didn't have the best sonographic window, and they will think more about, the clinical factors if they're still having significant pain or abnormal white count or all of those things. Then in that scenario, they might go on to do additional imaging. At least here, I think that serial ultrasound is underutilized. I'm a big fan of that, repeating it, 10 or 12 hours later. I feel like oftentimes here we just jump straight to either CT or MRI, whereas I do wish they would use serial ultrasound a little bit more often. But that was one other thing I wanted to ask you guys too, was in that first case you showed Hai-Tui with the, slightly bulbous look of the appendiceal tip. I feel like if we see the appendix on ultrasound, I'm a little bit biased, but in those scenarios where we see the appendix really well, I'm not sure that CT and MRI really adds a whole lot. The resolution of the appendix is oftentimes worse on those modalities compared to ultrasound. So I feel like we oftentimes, if we see the appendix and we put it in that kind of intermediate, we're not totally sure, maybe there's a little bit of thecogenic fat, maybe it's kind of borderline diameter. I feel like CT oftentimes doesn't really add that much information, but oftentimes they will go to that. And in those scenarios in particular, I do feel like serial ultrasound really does play a very valuable role over either CT or MRI, but I'm curious if you guys have any thoughts on that.
Yeah, I agree. I think for absolutely with you guys, if we can visualize it, then I think ultrasound is way better, because not only are you not radiating the kid, it's like you already know you can see it, and then you can compare basically apples to apples. Especially in the younger kids, I feel like the CT is sometimes embarrassing. Maybe I shouldn't admit this out loud, but like I can't even find it on the CT, you know, like, so.
You're not
like,
alone.
Okay.
Like skinny little kids, it's hard to find a normal appendix, CT, ultrasound, MR, whatever.
And especially if their equivocal appendix is due to like an enteritis, you know, like there's just like fluid filled bowel loops everywhere. And on CT, like, I'm like, oh my gosh, it's like so challenging and embarrassing. Like I can't even find it. So yeah, I'm 100% a proponent of just a follow-up ultrasound, just to see, like you said, it'll declare itself. And then the next question is, I know there were talks on like, you know, and especially in our, my former, you know, scoring system, there was like a scoring between complicated and uncomplicated, but clinically speaking, I don't think I've been at an institution where it mattered as much, just because most of the children do not get trialed into just antibiotics only for the uncomplicated cases. And I just wanted to know your guys' thoughts. Like, do you guys care too much about it, or does your surgeons care? You know, do they trial them on antibiotics and not do surgery? And then of course, you know, just to like define complicated and uncomplicated, like complicated would be any kind of like gangrenous perforation, anything where, you know, it's just not acute appendicitis alone.
Yeah, mostly my surgeons care about is there fluid collection. So do they need to drain, either they or who IR drain the fluid collection? And then they also want to know if there's an appendicolith is the other big thing. Because supposedly if there is one, they need to take it out, whether it's sooner rather than later. But you're right there, especially for the uncomplicated appendicitis, they're going to just antibiotic therapy alone a lot more. I'm sure if we went to a surgical conference, there would be tons of talks about this. And I'll be honest, I have not updated myself on the literature of how just antibiotic conservative management is like functioning long-term with these patients. But anecdotally, it seems to be what they do. And it seems to like, we aren't getting a ton of kids coming back with raging acute appendicitis a week or two later. So.
Yeah, we're very similar. The main thing they want to know from us is whether there's an abscess or fluid collection. You know, I think most of the literature says that we have pretty poor sensitivity for perforation. That's what we've seen here too. You know, oftentimes when we don't see a discrete perforation or discrete fluid collection, they go and take the appendix out, and there's, you know, a little micro perforation somewhere on pathology, which, you know, I'm not sure how much that really matters clinically, but so really they want to know if they can go in and take it out, or if they needed, you know, have an abscess drain placed by IR first. So yeah, that's kind of our approach here. The antibiotics, I rarely see that happen here. I think a lot of it depends on parental preference. If they really want to avoid surgery, then some of the surgeons here are open to it. But I haven't seen it happen a whole lot that the surgeons will suggest that as kind of a first line treatment.
Yeah, same. I haven't seen it a lot. And I don't think at least at the institutions where I've been, you know, we have that as a trial, like a systematic trial either. So I do need to look up some literature to see, you know, where that has been. So maybe someone in the audience with more experience can kind of chime in or let us know. All right, so moving on to some mimickers. So this are going to be some series of imaging kind of focus in the right lower quadrant, obviously, that are mimickers of appendicitis. So this is a 9-year-old male who came in with right lower quadrant pain. And with the cine, you can see a fairly normal looking appendix, but then if you do notice, there's like all these like little linear, very mobile, actively mobile structures. So we did call the appendix either normal or equivocal, I can't remember. And then the child ended up having a CT to follow up. Luckily, there was a little bit of fat around in the mesentery, so you know that there was no appendiceal fat stranding, so no acute appendicitis per se, but then the mucosa is very thickened and hyperemic, so likely secondary to just kind of inflammation related to the pinworms. So those little echogenic guys ended up being pinworms that were confirmed on like rectal exam. Kind of similar, but a little bit different in, I guess, organism. So this one is another long tubular structure. It's a little bit more hypoechoic, so it's not tiny and echogenic. And not only was it in kind of like the TI appendix region here, it was kind of all over the small bowel, which I do not have. And this turned out to be ascariasis infection or tapeworm. So sometimes you can kind of see all of these parasites if you look for them. So just kind of gross, but something to look for, because otherwise they may not know, or they won't be on appropriate treatment. So this is a case of a 9-year-old female with right lower quadrant pain. The appendix measured, I guess, borderline, maybe 6 millimeters or so. But the important thing here is that there's no fluid. So it is hypoechoic, and you might mistaken this for like fluid distension, but you actually see a thin echogenic line of mucosa. So in this case, you know, it's not fluid in here, is actually thickening of the lamina propria. And usually, you know, the cutoff of the measurement is 2 millimeters. And in this case, it's lymphoid hyperplasia, and they can have similar pain like appendicitis. And I know that one of my former colleagues published on this, and that some of these kids can go on to get appendicitis, or, you know, develop appendicitis, just because, as you can imagine, like an appendicolith causing obstruction, sometimes this can focally cause an obstruction, and then therefore, you know, bacteria and stuff can become stasis near their tip. And so you can make this diagnosis. It's not appendicitis and can be just treated with conservative management, but potentially, you know, they can come back, and just don't be biased that it's still lymphoid hyperplasia. Sometimes it can develop into appendicitis. This is another case where this 4-year-old male maybe has a little bit of increased fat to him, comes in with right lower quadrant pain. And, you know, when you ask them where the pain is, points right to this area, you put down the probe, and there's all of a sudden this triangular echogenic fat area in the right lower quadrant, or in this case, a little bit to the right side of the umbilical region. And so this is pretty characteristic of a mental infarction. And sometimes it can be mass-like, and it can push, you know, like have a little bit of mass effect on the bowel. And at first, the original reader was kind of concerned for mass, like a lipoma or something, and did suggest a CT, which kind of confirmed the omental infarction, and the patient was just treated conservatively. All right. So I love this case. Oh, sorry, go ahead.
Sorry, there's a question from the chat on that last case. Do you ever use elastography for omental infarction? We personally don't. I think we probably underutilize elastography in general. I only ever use it really for looking at the liver. But do you ever use elastography for something like this?
No, I have not, but I would love to hear more about that.
Yeah, definitely an interesting concept, but yeah, I'm definitely not familiar with it.
Yeah, I guess I don't know the normal echogenicity of fat versus infarcted fat to like know.
So this one is a 9-month-old male, and with abdominal pain and bright blood per rectum. So this is basically like my peak of my diagnosing on ultrasound, and I probably will never make this kind of awesome call ever again. But there was a appendix ultrasound, I think, or maybe an intussusception ultrasound, but we recognized that there was an appendix, and then there's another blind ending tubular structure. And so I was like, well, you know, maybe this is Meckel's diverticulitis, and it turned out to be exactly that. And here's a little bit of perforation, and that's why the patient kept coming in. And surprisingly, you know, they had like prior CTs and nuclear medicine studies, and I guess because there was no gastric mucosa or any other findings, it wasn't picked up. And once again, you know, with CTs being 9-month-old, it's really hard to even see the appendix. So I think we can diagnose more than just appendicitis. Like if you see other blind ending tubular structures, other little like outpouching that's abnormal, you know, in the right clinical context, you can definitely prospectively suggest Meckel's diverticulum or diverticulitis, or something along those lines. All right, so we're going to move away from appendicitis and kind of touch on intussusception real quick. So usually, you know, with the intussusception, you'll see small bowel and maybe even the appendix within it. Clinically, they'll present with these colicky pain. If you ever have performed any kind of reduction using either water-soluble contrast or air, you'll kind of see the current jelly stool afterwards. It looks a little scary, but that's pretty typical. You can sometimes palpate a mass, and of course, the first line modality is going to be ultrasound. What we do look for on ultrasound is going to be that target sign on the transverse plane, and then the longitudinal pseudokidney appearance. So, you know, it's pretty, I feel like it's now standard of care. You know, you just do the cine clips. We never really follow it up with any kind of more invasive like enemas to kind of confirm it. But I have noticed people say, you know, the ultrasound might be limited due to bowel gas, which I've been told by other people who are smarter than me, bowel gas is actually a good thing. So if you see bowel gas along the course of the colon, you know that there's nothing intussuscepting within it. So I don't feel like it's a limitation, but I you know, love to hear you guys' thoughts.
Yeah, no, I agree. And I'm from the younger generation, so we don't get as much focus on plain film, but I've been told the same thing. You know, if you have a radiograph that shows, you know, really nice bowel gas all throughout the cecum and ascending colon, then that's, you know, pretty effective at excluding intussusception. You know, the sonographic equivalent to that. Like I was saying before, if we try to look for the ileocecal valve, if we don't specifically see it, then we tell the tech to take a cine clip through the ascending colon just to, you know, just the expected anatomic location where we would expect to see an ileocolic intussusception if there was one. So I overall agree. I think if we see bowel gas there, it's overall reassuring.
I have to say, I've done several times, I have done an air reduction. I see distal small bowel gas. So I'm like, oh, I think I'm done, but I see a little small gas. So I go ultrasound after I do an air reduction. So there's like gas everywhere and you can still see. So I love, like, I don't care. Bowel gas, no bowel gas, ultrasound.
Yeah. Sounds good. Yeah. And sometimes, you know, like, I don't recommend like a KUB if I think there's constipation, but I've seen some people do that, or maybe, you know, just the ER afterwards too, but
yeah,
I don't know.
Like I typically do, but I don't specifically recommend it, but I feel like we oftentimes see them order it.
Yeah. Yeah. Agree. Probably just like a clinical thing. It's like, okay, now we ruled out this, let's get a KUB for pain. Okay. So just, I know time's gonna quickly run out. So just a quick thing about ileocolic and small bowel intussusception. And usually, you know, you want to differentiate between the two because one you can reduce and one you cannot. So for ileocolic, these are some kind of the parameters that's been published before. And then, you know, this is how you kind of do the measurements. These are the measurements for the small bowel. However, you know, nobody, I don't think, including myself, would sit around and do all these ratios and measurements. No offense to the authors, obviously, but my take home is that, you know, what has saved me is mainly location and mesenteric fat within the intussusception that you do see. So typically, you know, if there is an ileocolic intussusception, it's going to be peripheral. It's going to be along the course of the colon, you know, depending on how big the intussusception is, you know, it can go all the way to like the splenic flexure, but usually it's up in the right upper quadrant or the hepatic flexure. Inside the contents, you'll see the small bowel, probably the terminal ileum, and then you'll see the terminal ileum's associated mesenteric fat. So you'll always see the terminal ileum, you'll see the fat, and then you'll see the cecum or, you know, the ascending colon around it. And to me, like that's diagnostic of an ileocolic intussusception. The other, you know, contradistinction for a small bowel is that it'll be more central. You'll see colon, you know, peripheral to it, and then you'll see obviously a small bowel within something much smaller. And then here you don't see any of that extra mesentery within the small bowel that's being tethered in, as in the case of the ileocolic intussusception. So that's usually how I just kind of say, okay, small bowel or not. And as we alluded to, you know, air enemas, you can kind of push out the intussusceptum out from the intussuscept recipient. And then for the small bowel, usually there's a lead point. So either if it's ileo or, you know, just either it'll spontaneously reduce on its own or you'll have surgery. So here you can see that this is a hamartomas polyp in Putz-Jaeger syndrome. So interestingly, I don't know if we have time to discuss it. It might be worth it to kind of just mention it quickly. Like, do you guys have like an age limit to what when you say, hey, this is more likely there's going to be a lead point and I don't want to reduce it, or you just try anyways? And then if you do try and it's not successful, how long do you space them apart?
I'll start with the first question. Our surgeons want us to try to reduce anything because they say that if you even reduce it just a little bit, that's good for, bowel, to prevent bowel ischemia, basically. So for these older kids, I think it's mean, but we still attempt reductions.
Yeah, we do also. And we've kind of had similar conversations with our surgeons. They've also told us that, there's potential that if we can at least partially reduce it, they might be able to do it laparoscopically versus open. So we have these, even if we see a lead point in an older kid, we generally will at least try as long as the kid is clinically stable.
And then do you guys usually have any set timing to kind of like space out attempts if you feel like you've reduced a little bit, but not completely all the way?
So we have again a clinical pathway for these. So we do what's called a DRE, so a delayed repeat air enema. It's kind of at our discretion. If we get called in at 3 in the morning, we'll probably wait until 7 to do that repeat. If it's 6 in the evening and we want to getting ready to go home, we might try a repeat in an hour or so. So I think the literature says that the actual timing between them is not super important. Just want to give that bowel a little bit of time to kind of get rid of some of that edema before you try it again. So it can be anywhere between an hour to 6 or 8 hours between our repeat attempts. The other kind of caveat to that is the child has to be well appearing for us to go down that pathway. So we have a few criteria for that, as far as hypotension and tachycardia and all those types of things. So they have to meet the criteria for wellness to be able to be eligible for those delayed repeat attempts.
Ours is exactly the same, although we don't have a formal pathway.
Yeah. And then a quick question from the chat too.
You guys are very organized.
Yeah.
I know, I'm jealous.
And a couple quick chat questions. First one is, do you guys sedate at all? We do not sedate. Our kind of, thoughts on that are, having the kid cry in Valsalva is actually helpful for the reduction. So we do not sedate. The next question was a couple related to if you have a surgeon on standby. I know there was a paper published about whether a surgeon needed to be present or not, and the general thoughts are if the child is, generally well appearing, we don't even notify the surgeons really. We just bring them over and do it ourselves. And then kind of same thing about whether a nurse monitors the patient. We don't mandate that a nurse be present with the patient as long as they're, clinically well appearing. If they have any concerns about the clinical status of the patient, then we'll have a nurse come over and we'll have them be monitored. But again, if they meet those criteria for wellness, we don't require a nurse and we don't require monitoring during the attempt.
We're a little bit different. We still want the patient on monitors. We mandate an IV at least with fluids running at least KVO, so just a drip. And then some of the surgical trainees who are like super go-getters like to watch, but that's only at the beginning of the year, I find. And then at the end, like nobody ever comes. But these patients go to the surgical service to be admitted when they're finished. And so they get notified anyway. So we tell them before we do the reduction that there is one.
Yeah, I think currently our workflow is similar to Judy's, where, surgery is simultaneously notified if it's coming through the ED. And then a lot of the surgical residents will kind of swing by mainly to just, out of curiosity or just to say hi and just be there, not necessarily ready for backup of any sorts, because these kids are typically fairly well appearing. Interestingly too, I'm like kind of against like, taping the butt and all that, because I just feel like it causes more pain. But what we have been doing that I found out at CHLA is that we wrap the legs together with, just kind of like this like not bandage, but just like, I don't know exactly what it's called, but you just wrap them like a little mummy, but it just makes everything easier to hold. And I feel like I can reduce it much faster with that. And my tubing is super short, so all the air just goes straight in. So I don't know if you guys tried that, but that has increased my my success rate and just made things really fast for me.
Yeah, for older kids, we ace bandage the legs because
Yeah,
of course they're gonna fight you, and some of them are strong.
they are. Even my 18 months ones can outbeat
Yeah.
me quite a bit. And then I know lastly, like, we do have a lot of talks about, should it be reduced emergently or urgently? Because I know there's lots of talks on burnout and, being a pediatric radiologist, you're always essentially on call. And this is one of the main reasons for call. So, just wanted to throw it out there, something to think about. I know it's going to be hard to justify keeping a patient around, if we can go in. So, but there are publications out there, stating that there might not be any differences in outcomes. And so maybe that's something we can further explore as like a multi-institutional thing. All right, so I just want to throw that out there. And then negative positive equivocal cases for intussusception. So this is a recent case, like maybe last weekend or so. An ultrasound of the, I guess, right upper quadrant maybe. So it looks like the bowel is sort of in another bowel, but not that perfect target sign. And so this is kind of what it looks like on a still image, almost like a crescent moon with something echogenic in there. And so I don't know if anyone's still around out there, but if you guys want to take a stab at the QR code again and see what you think your diagnosis is. And we may not, wait too long on this just because we're running out of time. But essentially, yes, it's something else. It is on CT because we were, not 100% sure, did CT to look for other things. There was this target sign. It looked a little bit more target sign. And then there's this like sausage shaped thing. So we're thinking, oh, is there Meckel's? Is there something else? And it turned out to be chronic Ileocolic intussusception, but secondary to an inflammatory polyp. So there was a lead point in surgery. And then similarly, this is left upper quadrant, also another atypical kind of case where it's definitely not your typical ileocolic intussusception, and it turned out to be a colocolonic intussusception. And there looks like, once again, just something echogenic within it, and possibly a polyp or a lead point. And of course, if for sure it's colocolonic, would you still reduce it? And then this might be the very end.
Yeah, we have much more limited experience with this just because it's so much more rare, but there has been a couple instances kind of for same reasons that we talked about before, where surgery has asked us to at least attempt it, either to just, buy them some time and make their surgery, less urgent. So we have usually at least tried, so we will at least attempt it. We've been relatively successful, but again, relatively limited experience with that.
Yeah, ditto. I'm sure our surgeons would ask us to try to reduce it. I would probably be a little bit more ginger in how aggressive I am, especially if I'm suspecting a lead point. Like I'll do the best I can, but I won't try as hard as I would for just a routine ileocolic intussusception.
Yeah, I'm so glad you guys feel the same way as I do. Yes, so basically I was the recipient of the ask from our surgeons to try to reduce this. And I was able to kind of push that whole colon that was intussuscepted back a little bit. But of course, there's still a polyp there, which we knew. And eventually, I think GI had to end up going in and snaring it. So the same reasons our surgeon was like, if you can reduce something, keep it from being edematous, keep it from being losing any kind of blood supply. And so we would do that anyways. But ultimately they have to kind of remove the underlying cause. So just lastly, a lot of the mimickers is going to be perforated appendicitis. So both of these cases are younger children. So I just want to kind of throw it out there and say that, when you see something that looks like an ileocolic intussusception, but, doesn't quite fit it, always kind of think about acute appendicitis in the back of your head, because this one, we didn't have to do any kind of reduction unnecessarily, because these were both cases of perforated appendicitis. So to end, must use linear high frequency probe and obtain cine clips along the course of the colon. We love cine clips, and because it's May 4th, may the 4th be with you. Thank you.